In today's podcast, we would like to share our opinion and experience about doing a CL Psychiatry fellowship after finishing psychiatry residency. This podcast will be specifically useful for medical students, psychiatry residents, or early career psychiatrists who are interested in pursuing a career in CL psychiatry or would like to know more about it. For this purpose, I have two active members of ACLP CL psychiatrists with me today, Dr. Mark Bradley and Dr. Sejal Shah. Let's get started with some more introduction. Mark, can you introduce yourself to our audience and tell us more about your background in CL psychiatry?
Sure, Artin. Thank you very much again for having me on today. So my name's Mark Bradley. I am the program director for the NYU Fellowship in CL Psychiatry. I'm clinical professor of psychiatry at NYU. I'm section chief at the VA hospital in Manhattan, so I kind of oversee inpatient and CL clinical services there. And I've also been chair of the Fellowship Education Subcommittee for ACLP for the past year or two. And so I'm very lucky to get to work with Dr. Shah around more national level issues related to fellowship education as well. So I started my career in CL psychiatry really sort of fortuitously. I had started the university without really considering medical school. Actually was very interested in arts. But what happened was in the mid 1990s, I started to experience kind of the effects of the upsurge of the AIDS pandemic in my community and, very much around myself, my LGBTQ plus friends. And, while that was happening, there was also an upswell of social movements and social concern about the way that, AIDS impacted people who were vulnerable. And it really started me thinking about questions around who gets treatment, who doesn't get treatment, who is allowed to get sick and die, and who gets care. And I realized this was something I was really interested in. It was what I wanted to pursue. And so that was the point at which I entered medicine. Um, I was very lucky in med school for my first rotation in psychiatry to actually be a CL rotation. I'm talking to some of our applicants now, and it's always, very interesting to hear about people saying, I don't know how I would have discovered CL psychiatry if that hadn't happened to me, but I was lucky to have that experience. And I was working in a county hospital in Houston in med school, and my CL attending was Beth Udofsky, who was I just thought she was one of the most brilliant doctors I'd ever met. She had the ability to take a patient's story, to synthesize their most complex medical experiences, to integrate that with who this person was and how they function psychologically, and to think about their lives within the context of the hospital and their larger lives. And, it was almost like a work of art each way that she put together patients. And working with her for that month, I thought, this is exactly what I want to do. This is for me, the most complete way of being a doctor. And also in that process, I got to feel like I was making a difference in terms of working with patients with severe mental illness in the hospital. I felt like, this was a group of people who were not treated necessarily well, not understood by their doctors and nurses. And I felt very proud to get to take care of them. And then also seeing aspects of other kinds of medical illness that I was very interested in. I actually saw my first person with AIDS on that CL rotation when it was a young woman who had most likely contracted HIV from a sexual assault she had had a number of years earlier, and was dealing with not only PCP pneumonia, but the psychiatric ramifications of that event. And all of those things were really affecting each other. So it was a really life-changing month, and I realized this was really my mission. I was entering my rotations thinking I would probably do medicine or neurology, and ended up going into psychiatry. So I started residency specifically with an interest in doing CL. I was very interested in HIV psychiatry still. When I was a resident, we were going through the time when we were starting to see major changes in HIV care, the uptake of antiretrovirals. And then there were a lot of psychological and psychiatric aspects, that was really foregrounding in the care of patients. So, for example, all of a sudden, the ability of patients to take their medications effectively on a daily basis really meant the difference between whether they were going to survive this condition or not. And so much of that, it turned out, had to do with their mental health and their psychiatric illness and their psychological well-being and their ability to abstain from substances. So it really just enshrined in my whole being the idea that, really good medical care depends on active and thoughtful psychiatrists who really understand the medical context and the systems, as well as being really good psychiatric experts. So that was kind of my story. I did a CL fellowship. I did a research fellowship in HIV and behavior. And then I came to the VA, starting off working in primary care mental health integration. And then kind of as part of my journey, I just got very, very interested in education. And that ended up becoming a big and unexpected part of my job. And that takes me to, I think, where we are today.
Okay, great. Thank you so much for sharing this interesting and I think educational life stories with our audience. Now, Dr. Shaw, can you please introduce yourself?
Sure. Thanks, Artin. And thanks for having me on this podcast. It's a pleasure to be speaking with you all today. And I just want to say I've known Dr. Bradley for quite some time, and I just learned a lot about him. So I'm very excited about that. So I am CL Shaw. I am the Division Chief for Consultation-Liaison Psychiatry at Brigham and Women's Hospital in Boston, where I'm also the Associate Vice Chair for Clinical Consultation Services and an Assistant Professor of Psychiatry at Harvard Medical School. I'm the immediate past program director here at the Brigham, where I was appointed as the associate program director in 2012 and took over as program director in 2014. I am now co-leading the program with our current program director. I got to know Dr. Bradley very well through the ACLP Fellowship Education Subcommittee, where I've been a vice chair in the past, and now get to work with Dr. Bradley who's chair. So my story is, similar to Dr. Bradley, I actually did not know until pretty late that I was interested in a career in medicine. I went to college a bit lost, not knowing what I wanted to do. I decided between my sophomore and junior year that I wanted to apply to medical school. I was very interested in the brain. I was thinking maybe neurology, maybe psychiatry. Got to medical school, and very similar to Dr. Bradley, had my first exposure to psychiatry was in CL Psychiatry, and absolutely loved it. Thought that it was such a unique way to practice psychiatry and just practice medicine in general. And so decided to pursue residency in psychiatry, moved up to Boston. During residency, I really was still drawn to CL Psychiatry because it was the place where I really got to advocate for the most vulnerable patients across the hospital, in the emergency department, on the medical floors, surgical floors, and really got to just get to know patients and their families and get to hear their whole story. And that was really appealing to me. So I became chief resident on CL during residency during my 4th year, and then stayed at Brigham and Women's Hospital for a CL fellowship, where I was just felt like I was in my element. I was surrounded by people that were like-minded. I really got to grow my skills, being not only a good clinician, but also develop my liaison skills. That's where I became really, really interested in emergency psychiatry. It was the chaos of the emergency room was really appealing. I got to kind of work up a patient right from the beginning. And that's where we often saw patients that were just managing so much in their life. That's where I learned about how social determinants of health are so important, and where we can really advocate for patients when they don't have an advocate or can't advocate for themselves. It's also where I became interested in fellowship in hospital systems issues, and really learning that we as CL psychiatrists are really at the forefront of managing patients on every service across the hospital, and really get to develop relationships and work with others that want to think about quality improvement, patient safety, patient advocacy. And so got involved with a number of different projects there. And that's where my major mentor, Dave Gitlin, who was my program director at the time, really encouraged me to think about issues more broadly and really think about hospital systems. So I joined faculty at Brigham and Women's in 2012, where I was the associate program director, and then became program director in 2014. Really developed a strong interest in medical education, and really saw that CL Psychiatry fits in so nicely with education. It's what we do all day, every day, teaching others. And there's such a satisfaction in that, and such pride that I think we as CL psychiatrists take in that. And so was really able to develop that. And then I more recently, over the last about 3 to 4 years, actually have utilized my CL skills in moving into doing some hospital administration work in workplace safety and violence prevention in the hospital setting. So really looking at situations where patients might be make violent threats or have violent episodes, and really try to think holistically about what is the etiology of that, and how can we continue providing high quality care in a safe way for patients that may have tendencies to have threatening behaviors or agitation or violence. And I think we as particularly psychiatrists, but also CL psychiatrists, really understand that interface, and can really help hospital administration be more understanding and really think about things from a patient-centered standpoint. So I think that brings us to today.
Yeah, okay. So thank you so much both for being in our program. What I can hear is that the interest in CL psychiatry should develop from early medical school and residency, and it's kind of intertwined with the practice. I just want to briefly tell about my own experience to make a kind of encouraging statement for the international medical graduates. I'm an international medical graduate. I did my medical school back in Iran, in Tehran University. In Iran, medical school includes internship for general medicine, for family medicine. So people who graduate, they practice as general practitioners before being able to do any specialty, residency in a specialty. So I practiced for about 3 years as a general practitioner in a rural area in Baluchistan province, border of Iran and Pakistan. I was the only physician for a population of 7 to 10,000 people, and the nearest hospital was about, I think, 100-kilometer radius from us. So that was the time that I got really interested into psychiatry. I was the only physician seeing patients. I saw a lot of interactions, mind-body interactions, mental health, physical health interactions, a lot of patients with comorbidity of mental health and physical health. And I was the only one who was there to manage them or refer them to the hospital in the city. So that interest made me to apply for a master's in psychosomatic research at McGill University. And then I did my master's. During my master's, I did the exams for United States licensing and Canadian licensing, this Medical Council of Canada. Following my master's, I did my psychiatry residency at McGill University. My development in CL psychiatry, my interest developed during the psychiatry residency with my rotations in collaborative care, in family medicine, co-location with psychiatrists program that they had at McGill. And I decided to do a formal CL psychiatry fellowship in the United States. As in Canada, it's not yet a subspecialty or formal fellowship. So I applied for CL psychiatry, and I did my 1-year CL psychiatry fellowship at Hopkins. So now let's, all three of us, we have experience of doing CL psychiatry fellowship. I want to start with one question that I hear from a lot of my colleagues getting out of residency, and they ask, what is the necessity of doing a CL psychiatry fellowship when you can do CL psychiatry work even without a fellowship? So Dr. Shah, can you please share with us your personal experience and the reasons you think a psychiatry resident should consider doing CL Psychiatry fellowship.
Yeah, absolutely. It's such a great question, Artin. It's a question that we often get from applicants, from psychiatry residents, and also, colleagues that maybe didn't pursue CL initially and are maybe looking to get into CL work. And so it's such a great question. So without question, there are jobs out there that are CL, CL jobs that you can obtain without doing a CL fellowship. That definitely does exist. There's need out there. That being said, I think, if somebody is looking for a larger healthcare system or an urban area, or just an area that has a precedent of CL trained psychiatrists doing CL work, you likely need a fellowship in those areas. And so I think there is that distinction. For fellowship, obviously I'm a little biased, but I think a CL fellowship is just invaluable. I think that it provides excellent training and experiences in those nuances of CL work that you might not be able to obtain elsewhere. It gives you a great opportunity to think about hospital systems, quality improvement, liaison work. It allows you to develop subspecialty or niche areas of expertise, things like exposure to collaborative care or other areas within CL like perinatal psychiatry, transplantation psychiatry, burn psychiatry, how substance use care interfaces with CL psychiatry, critical care psychiatry, and the list goes on and on and on. It's a great way to get exposure to being embedded within various clinics, like primary care clinics, doing collaborative care, or doing outpatient consultative work, which is also very popular these days. I think one of the most important things that allowed me to do was develop a CL network of like-minded colleagues. The number one thing that I hear from my former fellows is that a CL fellowship really made them feel very comfortable with the most complex of cases. We're never going to know everything. We are lifelong learners, but we know when we don't know something and when we need to reach out. And I think that those nuances and the complexities of some of the cases that we see, both in the hospital setting and in the outpatient CL setting, fellowship really allows you to become kind of expert in those areas.
Okay, great. Good to know that there are some niches and some more areas of CL psychiatry that you can be exposed during the fellowship. Now, Dr. Bradley, what are your thoughts on that?
Yeah, so I certainly agree with everything Dr. Sajal said, and probably first and foremost that the community that I developed as part of becoming a CL psychiatrist, not something I necessarily thought about when I applied for a CL fellowship, which was really thinking more about job and, intellectual interest and that kind of thing. But did end up becoming what I see is now one of the major benefits of having trained in CL and become part of this larger family who share the same interests and passions, and who I also just cannot emphasize learn so much from. And it transforms your experience of trainee to attending to trainee to lifelong learner, and that's been a really big benefit of doing a fellowship. So I think when I'm thinking about the question of why would one do a fellowship, there's different aspects to that question, and there may be different elements of it that are more important for different people. So there's certainly market things. Are people asking to what extent is it possible to just get a job as a consultation psychiatrist without doing a CL fellowship? And like Dr. Sajal said, that is certainly possible. It's certainly possible. And, from a practical point of view, it's more possible in some places than others. So I think if that is one element of consideration for the person asking that question, I would say it's very important to look at the potential job market where you plan to work. If you are planning to work, for example, in an academic center in New York City, I would say, as a consult psychiatrist, I would say it would be a very good idea to do CL training. The same may be true for Boston and for other major cities as well, and that may be less critical just in terms of obtaining a job as you get further out from concentrated urban centers or academic medical centers. I think another aspect to that question is just the idea of satisfaction and job satisfaction and personal growth that you do as part of being a consultation psychiatrist. So one of the reasons why I think those of us who did fellowships gravitated to doing it is that we knew we liked this kind of work, but we wanted to be able to engage with this work with a particular kind of expertise and satisfaction and joy and growth and knowledge, and also to not only simply provide clinical care to the patients that we're seeing in front of us on medical or surgical services, but to have a sufficient amount of training that we can actually serve as experts to our colleagues in medicine and surgery who are asking for our help. And that expertise, oftentimes, as CL psychiatrists know, is not just what is the dose of medication to start, even though that may be the manifest question, but it's how do we solve this much more complex problem that's going on that involve the patient's behavior in the hospital, the feelings of the doctors and nurses about the patient, how to ensure this patient's continuity of care in the next step of care, how this patient at a psychological level is experiencing their illness and their experience of being in the hospital. So the problems are often much more complicated, more integrated than what we encounter in psychiatry. And one of the whole points of a CL fellowship is to prepare us to answer those kinds of questions. And it makes the work much more satisfying and much more engaging. If without that training, I would say consultative work, and I've seen this in colleagues, sometimes who are moonlighting as consultation psychiatrists, often can feel frustrated by the challenges that they're presented with because they don't fully understand what is at stake or what needs to be understood. And that, again, is just a training issue. They're very good psychiatrists, but they've not been trained to work in this particular kind of context. So I think the enjoyment and flourishing in the work is really important. Another aspect is there are specific subject areas in CL psychiatry that just become part of what we learn and what we do. So within a CL fellowship and within the preparation for the CL boards, we learn about specific areas of medical functioning that have specific impacts on a patient's psychiatric life. So that includes, I mentioned the example of HIV/AIDS before. HIV/AIDS has manifold effects on a person's psychiatric functioning. That's something we generally don't learn in depth in residency. You very much learn it in depth as a CL psychiatry fellow. The same applies to women's mental health and reproductive psychiatry, to psycho-oncology, to GI aspects of psychiatric illness, to post-surgical care, and the list goes on and on. So that specific kind of expertise, again, makes the work in, as a consultation psychiatrist, serving as expertise and support for your colleagues much more satisfying and makes you very valued when you're working in that kind of context. Another aspect is there's a question of what is available to you in terms of your first job, but I think there's also a larger career question of where do you want your career to grow? How do you want it to grow? Do you want to work in academics? Do you want to have a leadership position? So Dr. Shaw is talking about how her CL expertise is part of how she understands hospital systems. This has been very much true for me as well at the VA. Working with medicine, working with surgery at a systems level, thinking about how psychiatric aspects affect, systems of care within our larger general hospitals. So that potential for leadership opportunities within the hospitals is very important to think about. I think when you're thinking about doing a fellowship versus simply going straight into a consultation job, because that can have very important implications. And certainly the academic part, if you're interested in having an academic career in an academic medical center in CL psychiatry, I think it actually is very important to get CL training. And I think that does make a big difference in terms of facilitating that. I think that's just objectively true. And then again, having the opportunity to be a part of ACLP, to get to know other CL psychiatrists, to really learn and grow over the course of your career, I think is just, it can't be overstated as an opportunity, as in a one-year investment in a CL fellowship.
Okay, great. Thank you so much. I can really speak to the, the positive things you can get during the fellowship as transition into attending. I think as a resident, you usually staff your cases, get supervision for your cases, and then when you are an attending, you're at the point that you should supervise others and supervise juniors. So CL fellowship, especially for complex medical cases, it has been a great segue transition from that residency to the attending. And I can also speak to the opportunity to get great mentors during the CL fellowship, mentors that you can guide you through your career as a psychiatrist, early career psychiatrist, to help you and guide you how you can shape your future career and where you want to see yourself. So that's great. These are all nice points. Now, I would like to get to my next question, which is kind of expanding my first question to get into the point what kind of skills a resident can add to his skill set, because we know the residents, they do a lot of different rotations during residency, and some of the rotations include CL, collaborative care. So when a psychiatry resident graduate will do a CL fellowship, what skills do they add to their skill set?
Should I start?
Yes.
Yes. Okay. So, well, there are skills that I think fall into specific skill areas. And then I think there are skills that have to do with your general growth as a sophisticated clinician that happens as a result of being a CL psychiatrist. So we kind of talked about how within a CL psychiatry fellowship, you become more expert within specific domains of medical care. And that is a big part of CL psychiatry. You spend time in surgical settings. You spend time in a number of subspecialty areas that may vary based on the fellowship, but represent areas of specific expertise that you simply don't get as a resident, but are very important if you're going to be working in a complex medical context. There are other areas that are somewhat more general, but we learn them in more depth as CL psychiatrists. So examples of that would be, I would say when I completed residency, I was not particularly expert in drug interactions. It was just something that I had a very cursory understanding of. I probably knew enough to pass the board exam, but that was about it. And it's one element of CL psychiatry. And this is just sort of an example of many things where we do it in residency, but it becomes much more developed over the course of your fellowship year. And I could sort of rattle off a few examples of this, but some others that might include would be the interpretation of EKGs. Again, we have to know something about QTC prolongation when we're residents in psychiatry. Most of our fellows by the end of fellowship are looking at the EKG, breaking it down, understanding what the different formulas that are used to actually calculate the QTC, when you should use one versus another. In some ways, a higher level of understanding of an EKG than in terms of QTC prolongation than many of our medicine colleagues. Substance use disorders, again, we get pretty good training in that in residency, but in fellowship, we are often doing things that are just much more complex than we do in residency because the level of clinical care for our patients requires it. So this may include how to manage methadone or buprenorphine in the perioperative setting in a patient with substance use disorder who's going to go through some degree of withdrawal, has complex pain, and may also experience cravings if they have a reduction in their opioid replacement, how to microinduce buprenorphine in the setting of somebody who's already on opioids. So things that are more specialized versions of things that we learned in psychiatry. Other aspects of that have to do with communication skills and professionalism that are very, very sophisticated for the CL psychiatrist. So as psychiatrists, obviously we're meant to be and trained to be good communicators, and we generally are thinking about how to do that across the patient's physician dyad between the patient and the psychiatrist. But in CL psychiatry, we're thinking about how is communication operating across teams between different levels of medical hierarchies among disciplines and multidisciplinary settings. How do we think about the motivations of one group of professionals versus another? How do we weigh people's concerns when a patient is not participating in care in the way that we would like them to? How do we find good outcomes? One thing that I will sometimes say to my resident trainees in particular is that, you know, there's a lot about CL psychiatry that's very intellectually rewarding, because we will talk for hours about how a particular lesion has changed a person's personality or cognition, and then talk about, you know, how the patient's early childhood is, you know, sort of shaping the way that they understand their illness and hospitalization. But the bottom line is we're a very practical, solutions-focused subspecialty, and we take that information and we learn how to use it to actually achieve a particular aim, which is, you know, to help an internist or a surgeon ensure that their patient is successfully completing their hospital care or their outpatient care in the way that we need them to. So that level of sort of integration of, you know, kind of your highest level training in psychiatry into very sort of practical solutions is something that I don't think you really get as a general resident. Because as a general resident, we're generally thinking about how to, you know, how to treat the individual patient. So I think for me, those are things that come to mind in terms of, you know, what I experience, what I see my fellows experience as they transition from resident to CL fellowship graduate.
Okay, good. Thank you. Dr. Shah, do you want to add some of the other skills you think the residents can get during the CL fellowship?
Yeah, absolutely. I agree completely with what Dr. Bradley said. And, you know, he covered so much of what comes to my mind as well when I think about the skill set of what CL fellows can obtain in that 1 year of training. I really think about it as a deepening of the level of expertise. You know, every resident gets exposure to CL, but that deep level or that nuanced perspective is something that is obtained during fellowship. Medication interactions are exactly what came to mind when I think about this as well. You know, learning about all of the different chemotherapy agents and how they interact with our antidepressants or antipsychotics or mood stabilizers. That's something that I have become expert in, which I feel just so comfortable managing really complex patients. Patients with cancer, patients with other kind of complex medical illness. The other things that come to mind are we really also become experts in mental health law and the interface with forensic psychiatry. So that's been something that has been really interesting, challenging, rewarding, and all of our CL fellows get exposure to that. And then also thinking about psychotherapy in the medical setting. So I think that there is often this myth of, oh, well, CL psychiatrists, you know, they leave psychotherapy and psychoanalytic techniques behind. And it's really quite the opposite. It's how do you hone those techniques in a setting where you maybe only have a few minutes because a patient is very drowsy or can only participate in an interview for about 10 minutes or even 5 minutes. What are some CBT techniques that I can use at the bedside? What are, you know, how can I motivate a patient to participate in care? What motivational interviewing techniques can I use? That sort of thing. So that's something that is really emphasized in CL fellowships. And then the last thing I'll say is it really allows trainees to take on that junior attending role, that where, you know, in residency, it really is, you know, you're in the role of a trainee, but fellowship I see as this really great opportunity to develop styles of how you know, you want to be as an attending. And I think most CL fellowships, the faculty really treat their fellows as junior attendings. And so really providing that kind of extra level of autonomy, which I think is really great.
Okay, thank you. So what I hear and what I learn is a CL fellow will get a lot of exposure to complex medical psychiatric comorbidities, drug interactions, and more in-depth learning of clinical scenarios that they might have had brief exposure during the residency. So let's talk about the cases and clinical work that a CL fellow might encounter during the fellowship. So I would like to know, and I think our audience maybe would like to know more about the patient population in CL psychiatry settings, clinical scenarios that a fellow will encounter, and most of all, I think an overall day-to-day work of a CL psychiatry fellow. Dr. Shah, do you want to take a stab at that?
Yeah, another great question. So I think it's so important to know, if you're thinking about a career in CL, what does your day look like? So I think that's such a great question. Types of patients and patient populations that you might see. So depending on, it's of course dependent upon the specific setting that you're in, but I think the one of the big kind of categorizations is often, inpatient, hospital-based CL, and then outpatient, more like outpatient consultation or collaborative care. So those are two kind of big buckets that I think about when I think about kind of categorizing CL work. I'll talk a little bit more about, I spend most of my time on the inpatient CL side, which is hospital-based. So I'll talk a little bit about some patient populations that we see in various types of cases that we see on my service. So we do not have a psychiatric emergency room. And so we see patients in the emergency room as well as the medical surgical floors. A big part of our population is also we're the largest birthing center in the state of Massachusetts. And so we see a lot of perinatal psychiatry. In terms of kind of specific types of cases, so I think bread and butter for CL is often acute delirium. So that's really what comes to mind when I think about CL work. For anybody that manages patients with delirium, that one case is never the same as the next. And so even though we kind of put it in the bucket of delirium, every case is a little bit different, both psychiatrically, neuropsychiatrically, medically. So really interesting types of cases to see. We also see really complex neuropsychiatric presentations, often becoming kind of investigators trying to determine and crack the case in terms of what's going on with the patient. We do a lot of evaluations of medical decision-making capacity. So those are also very interesting cases and very different from one to the next. Pre-transplantation assessments, management of various behaviors in the hospital. So it might be related to a personality disorder, maybe related to how a patient interacts with the healthcare system, which is often related to their previous interactions with the healthcare system. Maybe related to previous experiences that they've had within the healthcare system, previous traumas that they might have had within the healthcare system, really helping advocate for patients in those contexts with the medical team so that a patient can receive the care that they need. Management of agitation, and as we all know, lots of etiologies of agitation, so we are often called for that. Primary psychiatric complaints, so episodes of psychosis, mood symptoms, related to either hypomania, mania, depressive symptoms. And then a lot of what we manage is demoralization in the hospital. That becomes just such a common scenario that we are often called for. Patients that are very discouraged due to loss of functionality or new diagnoses or prolonged hospital stays. And then another big bucket that I think about is really liaison work. Sometimes our work does not lie with the patient, or lies very little with the patient, but really lies with helping the team manage the care of the patient. So lots of collaboration with medical teams, lots of education and teaching, which then often leads to collaboration on things like quality improvement projects, research projects. In terms of day-to-day work, I think what's really exciting about CL is that it is so varied and one day is never like the next. And so that's what makes it exciting. That's what makes it challenging. It's what really kind of challenges me each day. And I am constantly learning new things. Like I already mentioned, each case is just vastly different from the previous one. So I think those are some of the things that kind of come to mind when I think about day-to-day CL work.
Okay, great. Good to know the bread and butter of inpatient CL consultations, psychiatric consultations in CL service. Dr. Bradley, would you like to add something about maybe the collaborative care outpatient part, and then if you have anything to add for the inpatient part?
Certainly, yes. So I guess starting with collaborative care, one of the things that's very interested about integrated care within CL Psychiatry is that there are all of these models of integrated care that's developed over years and decades that were really outgrowths of the desire to help patients within specific patient populations. And so as our fellows rotate through different kinds of integrated care clinics, they're thinking about the care of the patients in front of them, but they're also thinking about, so why do we do it this way for this particular patient population? So an example would be, well, several examples. I keep coming back to HIV/AIDS because it was really my early interest, but AIDS, HIV/AIDS clinics from early on recognized that there were multiple issues that were important for their patients. This included issues around stigma. It included early on very unusual presentations of neuropsychiatric manifestations of AIDS. It included a lot of mood disorders, substance use disorders, a lot of issues around integration with social support. So the shape of the way integrated care for HIV/AIDS developed in a particular way and looks the way that it does today because of that history. And again, when somebody rotates through an HIV/AIDS clinic, they come to understand that. Why are we focusing on this particular structure that supports adherence in the way that we do? Psycho-oncology has its own specific history that's developed to meet the needs of patients with cancer. Women's mental health and reproductive psychiatry has its own history. So the shape of all of these forms of outpatient care look very different and have different histories as the fellows rotating through them. Collaborative care, as you mentioned, is a form of integrated care that was developed to meet the needs of a large number of depressed patients with major depressive disorder within a patient population and within a community that may not have a high access to psychiatrists. So again, it's the patients that we're seeing in front of us, but it's also understanding why does this particular system of care that we're using support the needs of this patient population. And that is so there's all of the clinical aspects of that happen at the level of the individual patient. Certainly in a women's mental health outpatient setting, how do we ensure that this woman who is a person with psychiatric illness is able to plan their reproductive life, prepare safely for a pregnancy if that's what they choose to do, have the best possible outcome for their pregnancy. In HIV psychiatry, how do we ensure that this person who's living with HIV/AIDS has excellent HIV/AIDS outcomes, has their psychiatric illness and substance use disorders well controlled, and are living with dignity and good support? So there's specific clinical issues in terms of the way we treat patients psychiatrically, but there's also how do we think about the way care is being provided for each of these patient populations within a particular system of care. So to the extent that fellows have the opportunity to rotate through those clinics, that's a very important part of that. Another example, which is somewhat unusual, at Bellevue, which is one of our fellows' hospitals, we have a program for the survivors of torture, which is run by Asher Elijam, who's a CL psychiatrist. He's been the director of that clinic for a couple of decades. And again, the idea is how do we serve this patient population who's coming from their countries of origin with histories of political abuse and mistreatment, and provide them care that they need to function optimally in this country and have a good quality of life. And that for them is going to involve social work, paralegal care, psychiatric, psychological, thinking about what languages they use, what cultures they participate in, dentistry, OB-GYN, internal medicine, things that address the specific aspects of physical mistreatment that they might have experienced. So all of these really are thinking about, how do we provide psychiatric care safely given the medications or medical conditions these people may have, but also how do we address them as a member of this underlying patient population with particular needs. And I think that is really interesting work that is part of the maturation of a CL psychiatrist and thinking about things at a systems level.
Okay, good. I can speak a little bit more to the outpatient aspect of CL, which is my area of interest. I was lucky to have the opportunity of doing 50% of my fellowship in outpatient CL in the program that I did, and I did part of it in neuropsychiatry and traumatic brain injury clinic, and that was so exciting and interesting to see patients with all neurological conditions, multiple sclerosis, strokes, Parkinson's disease, and the comorbid psychiatric condition, mostly depression, anxiety, mood and anxiety conditions, and the medication management of those complex patients with the neurologic condition. And then another part of my outpatient experience was co-location in a family medicine practice in the community. And that opened my eye into another population of patients with mental health conditions that are having severe and persistent mental health conditions, but are managed by our family medicine colleagues in the community. They are not in an acute phase to come to a psychiatric hospital or psychiatric setting. And that was also a stimulating experience in terms of managing this patient population with our family medicine colleagues. Now, I think so far we talked a lot about the advantages and the positive aspects of doing a CL fellowship to encourage our colleagues in their psychiatry residency to consider CL psychiatry fellowship. We know that unfortunately, life is not designed to be perfect, and I come from a critical, point of view most of the times, people who know me. So now I want to ask my next question. What are the downsides of doing a CL fellowship? And what didn't you like about your CL psychiatry fellowship, or what you expect that the residents in general, if they do a fellowship, they might encounter that they wouldn't like? So let's start with Dr. Bradley.
Well, see, I see the world through rose-colored glasses, unlike you, Artin, so I'm probably the wrong person to ask. But no, really, so I don't know that there was a part of my fellowship that I can say I didn't enjoy. It was a year. Actually, I did it over 2 years because I was doing a half-time fellowship with a research fellowship. But it was a very enjoyable experience for me. Now, that being said, there were certainly things about the fellowship that were very difficult, very challenging, where, it was definitely some degree of growth through some degree of fear. I think pain might be a little too strong a word, but, there were some growing pains in it. And, there are difficult, stressful moments. I remember early on, I had a patient who was going into respiratory failure, and the primary team was convinced it was alcohol withdrawal. And I did not think the patient was an alcohol withdrawal. And that was my first experience with, I am having some disagreement with the primary team. They are stressed. I am stressed. I think I'm right, but I just finished residency, so I'm not sure. And this person's about to go to the ICU, and they're asking me for my recommendations. Looking back, that was a great experience that I would not trade for anything, because I learned so much about it. I learned a lot about how to communicate what I thought was actually correct and was going to help the patient, which in this case was, I felt that they needed to urgently be looking for other etiologies of this person's respiratory failure. And that ended up being the right thing to do. But boy, was it stressful at the moment, but a great learning experience. And, one of those things that I look back and I draw from. And I tell my trainees, the things that you draw from when you're an attending and you're dealing with something very difficult are not your classroom lectures. They're not, the fun patients that you remember fondly and is also wonderful and enriching, but it's probably your most difficult moments that you had as a fellowship. And the good thing about a fellowship, as happened in this situation, was I had the benefit of somebody senior to me who was able to shepherd me through that process to some degree, not as much shepherding as I would have gotten as, a PGY2, but enough that I was able to learn from it, take ownership of it, but also to get the support and processing of the experience that I need. So there were a lot of things like that, things where you feel like your fund of knowledge and your skills are being pushed, and that is uncomfortable, but it is absolutely a really gratifying part of the learning process. And what you really see as that's happening is your own mastery developing over the year. So it's, CL psychiatry is people don't do it because they think it's a cushy job. They do it because there are a lot of things about it that are challenging. But the good thing about a fellowship, even though there are moments that feel challenging and that feel stressful, they are completely outweighed by the gratification of seeing yourself get really good at it and what you are able to contribute then as a result of that, both to your patient's care and to your colleagues who really need your help. So I think that's the best way I could probably talk about what I would see as, the downside, which is it's probably, less easy than doing something that's a truly easy job.
Yeah, good. So I really liked to hear the growing pain notion. Just finishing my fellowship, I can feel the gratification of all the pain I went through during the fellowship. And it was kind of having a purpose of growth and mastery of the work as a CL psychiatrist. We can speak to that, I think, later, the growing pain of doing the fellowship. Dr. Shah?
Yeah, so I agree with Dr. Bradley completely. I also like the concept of thinking about it as growing pains. A couple things that I would add would be, in particularly on the inpatient CL side, it's not your patient. And so, the primary team is often taking in recommendations from multiple teams, and also making their own decisions. And so, one of the growing pains that I definitely went through and now I teach residents and fellows about is it's okay if your recommendations aren't taken. But that's one of the things that I think about that's often hard about inpatient CL is that when it's not you're not the primary kind of provider, what does that mean? And is it okay if your recommendations aren't taken? I've been in similar situations to what Dr. Bradley has described about his patient in respiratory failure, and really feeling like where's the line of advocacy versus really letting the primary team take the lead. So I think that's one of the challenges of the work, but I think that's what fellowship is really there for, is getting that supervision and mentorship around that. So I wouldn't, just like Dr. Bradley, I don't know if I'd call it a downside, but really an opportunity for growth. And the other thing that I would say is, given that it's such a busy clinical year in most, CL fellowship programs, it really puts you in the position of absorbing the affect of the hospital. The hospital itself is managing really complex, challenging patients, and sometimes situations go awry, or unexpected clinical outcomes happen, or difficult and challenging behaviors are being dealt with on all sides. And so oftentimes that's when CL psychiatry is called in. I think of it as very flattering that we have the expertise to be able to sort through a lot of that, and be able to help not only the primary team in managing those situations, but really in that process advocating for the patient in being able to get the best care possible. So I think those are maybe some of the challenges of CL work that definitely comes across during a busy CL fellowship year, but the growth opportunities are just vast.
Okay, good. I think I can talk about another area of growth that I experienced, and that's the unpredictability of the inpatient CL. One day you might have 1 consult or no consults, and one day 5 consults, and you should be able to learn how to manage your time in the best way to do the work. And I think that's one of the areas that you feel pain in the beginning, and you feel you are grown up towards the end of the fellowship, to the point that you can manage your time and manage seeing all the consults and put priorities. Sometimes you don't need to see all the consults in one day. which ones need to be seen today, which ones are the priority. That's the area that you will learn during the fellowship. So I think so far we talked about advantages, disadvantages, and I think our audience are to the point that they decide whether they want to do a CL fellowship or not. So can you please tell me if a psychiatry resident is interested in CL psychiatry and would like to do a fellowship, what should they do in preparation for the fellowship application throughout their residency and mostly towards the end of the residency? Dr. Bradley?
So I think this, there's a couple of parts to that question. One is, how do you become familiar with CL psychiatry as a subspecialty to be prepared and to understand, what this future might look like for you? One of the things that I would strongly recommend for people who are interested in CL psychiatry as trainees, and I would say earlier the better. If you're thinking about this as a med student, if you're thinking about this as an early resident or even a later resident, to really get to know, love, enjoy the Academy of CL Psychiatry, because they are very interested in helping you figure this stuff out. Of course, they're interested in bringing people into our subspecialty, but there are also trainees who join ACLP who don't go into CL psychiatry, but they have an amazing mentorship and learning experience in the process, and it helps them figure out what they want to do. So the Academy of CL Psychiatry has lots of opportunities for trainees to engage with. Those might include special interest groups. So if there are particular aspects of CL psychiatry, whether it's neuropsychiatry, whether it's HIV/AIDS, women's mental health, ethics, psychotherapy, quality improvements, there is likely to be a special interest group that you can join, get on their mailing list. You can get involved in you can get involved in projects that they're working on. You can get on their monthly phone calls. There's also a mentorship program through ACLP. And so if you're thinking about doing this work in the future, it's a great idea to get a mentor as a resident. And I think, and to, apply for a mentor, get paired, work with that person for a year, get questions answered, have this person help develop your interests. And that is a great way to get to know more about the field. I would definitely seek out the CL psychiatrists at your institution, if you have any, and let them know that you are interested in CL psychiatry. Many of us go into this work because, like Dr. Shah said, we love to teach. And so, it's sort of like built into our makeup that we want to kind of give, of what we have to other people, because that's part of what makes us thrive. And so definitely find the CL psychiatrists who are in your vicinity, if you have any, to learn more about the field, maybe develop some kind of informal mentorship. And the other thing is I would say from the point of view of ACLP, I'm always really impressed when, as a resident, people have actually gone to the meetings, if they're applying to fellowship, if they have submitted posters or, in some other way kind of participated in a substantive way in the work of ACLP. It's not required, but it definitely suggests that this person's really given this some thought and has had a chance to vet their interests, and they're excited by this. I know that as myself, one of the things I feel like I look for in fellows when we're going through the selection process is who feels really excited by what we do, because as faculty we generally find this really exciting and really interesting, and so it's a real pleasure to us to have fellows who join our program who share that and come to work really revved up by what we're doing. And when we see people have submitted posters and that kind of thing, it just shows that they were already excited by this before they even got here. So I think those are the things that come to my mind. Certainly it's a good idea, if you can do electives or that sort of thing, just to, get a little bit more experience. That's always helpful, but certainly not necessary, but maybe helpful just for individual applicants thinking about their potential future in this work.
Okay, great, thanks. I can say that the mentorship aspect of ACLP was very helpful to me personally. I would like to take the opportunity and thank Dr. Pierre Azam, who was my mentor during my PGY3, PGY4, walking me through all the application process for the ACLP. Now, Dr. Shaw, anything to add for the residents who are interested in CL fellowship?
I don't know if I have much to add to both of your comprehensive kind of overviews of how to prepare. The only thing I'll say is, I'll emphasize that ACLP is such a great resource. The mentorship program, special interest groups, just getting to know people in that CL network, I think is really, really helpful. And along those same lines, if there's anybody at your institution or neighboring institutions or just somebody that you know in your network that is doing CL work, talk to as many people as possible. Everyone has a different, level of involvement, but may have different interests or passions that they can talk to you about. You may learn something about CL psychiatry that you might not have gotten exposure to in residency, and so you'll get to learn something about it and just better prepare yourself kind of walking into a career in CL and definitely a CL fellowship. I completely agree with Mark that, going to an ACLP annual meeting or presenting a poster, although is great, I would say it's not required. So don't feel that you have to have multiple poster presentations, articles written within, CL topics. All of those things are great and fun to talk about during an interview, but as long as you show that you have an interest in CL and that you're passionate about it, like Dr. Bradley said, that's what's most important. And so, at your fellowship interview, what I want to hear about is what gets you excited about this work, and what made you think about CL, and why are you passionate about it? The only other thing I'll say is the big thing, in CL psychiatry is being a team player. You're working in teams no matter what. And so if you can get across either in your personal statement or in your interview that, why you like working in teams or what you find both challenging and rewarding about it, those are some of the things that I love to hear about.
Okay, great. And now, briefly, can one of you who is more familiar tell us about the whole process of application for the CL fellowship and how competitive these fellowship programs are?
I can take that and see if Dr. Bradley has anything to add. So the application process, so I think it's become a lot more streamlined in that most fellowship programs are using the ACLP Common Application, which can be found on the ACLP website. And that has allowed you to really send the same application to multiple programs, which is really helpful. All of the programs that are listed on the ACLP website, all of the CL fellowship programs are involved in the NRMP match program. And so just like residency, we go through match. And each of the programs that are listed have a link to their own program website. And so that's where you can often find some of the specifics of each program, such as what requirements they have for, let's say, your letters of recommendation. I would say definitely talk to your letter writers early. It is, although we participate in the match program, the process for interviews for most programs is through a rolling application process. And so once they have all your application materials, they will review your application and then offer you an interview. And the earlier you get all those materials in, it's likely that the more choices of dates for interviews that you'll have. And so that can be a positive. Preparing for interviews, I think, is something else that we can maybe talk briefly about. I mentioned a little bit about kind of what program directors might want to hear about, but definitely be familiar with everything that's on your CV, specifically anything that might be CL related, and really kind of getting across why that program is a place that you're looking at, what you're looking for in fellowship, that you like working in teams, and if you happen to have any, you don't have to, but if there are areas of CL that you're interested in. In terms of how competitive programs are, so CL fellowship is definitely a buyer's market, the applicant being the buyer. During the 2022 match cycle, there were 126 certified positions in CL, and 83 of those were filled. So you can see that there definitely were open positions. And so, we always encourage applicants that are applying to CL Fellowship, apply broadly. Don't think that there are any programs that you may not have a shot at. Definitely apply and be confident that, the programs that are out there provide great training, and you definitely have a shot at matching at the program of your choice. Dr. Bradley, anything to add?
No, that was super comprehensive. I think the only other things I can think of are, unlike residency and some of our subspecialties, we have not yet moved to ERAS. So that means that applicants should, like Dr. Shah said, look at the listed programs on the ACLP website that lists them and look at their individual pages to look at any specific requirements that they may have in terms of numbers of letters. Also, the dates for applications may, vary slightly in terms of final dates for applications accepted, that sort of thing. And the other thing to mention, which everybody probably knows, is that for this current year, we're still doing only virtual interviews like other programs. We don't know what that's going to be next year. So this may be something, just because many people applying now may be so used to everything being virtual that it's hard to imagine that once interviews were actually in person. But just something to think about for, if I was PGY 2 or 3, thinking about starting to prepare for the application process, I probably would just have that in the back of my mind, that this is an evolving world that we live in, and we're not quite sure whether we're going to at some point go to a hybrid interview situation, or whether it's possible that programs will go back to in-person interviews. So that's just something that the world has yet to figure out.
Okay, thank you. All this brought me back to the time of application for CL Fellowship, and I remember coming from Canada. I did my residency in Canada. As I said, looking at the list of programs, more than 100 positions available. It was difficult for me to choose which program should I apply to, which program should I rank. So now it takes me to my next question. Can you help our applicants to know what are the elements to consider when they're choosing the programs that they want to apply to? Dr. Bradley?
Sure. So, like Dr. Shah said, it really is a buyer's market. So what that means is applicants should think about what kind of a program they would like to attend. And that can mean any number of things. That can mean, where they want to live in terms of geography. It certainly can mean what kind of patients they want to work with. So if you don't see yourself working in a inner city safety net hospital going forward for the rest of your life, it may not make sense to focus on those programs, however good they may be, for your application process. So what kind of patients do you want to train with? A lot of programs are known now for specific areas of specialization. So to cite a very obvious one, Memorial Sloan Kettering we've had, which is a fellowship program that's very famous for its cancer care. We have had residents in our residency who knew that that's the work that they want to do. And so their applications really focused on programs that provided very strong cancer care training as part of their program. So I think that's very important, thinking about what kind of specialty training you might want to get, particularly if there's a subspecialty area of CL that you're interested in. And I think the other thing is, who do you see as role models? And this, again, is where it can sometimes be helpful to get a sense of the larger CL community by becoming familiar with ACLP. Who are people that represent values, personality style, mentorship style? Sometimes it's a matter of just, do you click with this, with this program director or this group of faculty? Some programs are extremely gregarious. Some programs, I always think programs actually have a personality, if you can think about it that way. Some are very sort of gregarious and, outgoing and funny, and some are very sort of calm and intellectual and reserved, and there may be a good fit there as well. If you have a particular dream trajectory, it's sometimes good to look at programs where somebody is, pursuing that, or you can see that they have a way to sort of open that up for you. And that's good to talk about during an interview to some degree as well. If you're interested in a program for a particular reason or particular expertise or particular resources that are there, I think it's okay and probably a good idea to talk about that, because it shows good fit and also shows that you have particular reasons for wanting to come and train there.
Okay, Dr. Shah, anything to add?
Yeah, I agree that location is probably the number one thing. Although you spend a lot of time in your fellowship program doing clinical work, you spend a lot of time outside of that. And so you want to be happy where you are. Does that mean being close to family? Does that mean being far away from family? Does that mean being close to friends in a place where you already know people or not? That sort of thing. And then type of clinical setting. So if you're looking for a tertiary quaternary care patient population, and that's something that you want to work with for the rest of your career, and you know that already, then that might be kind of a good way to narrow down programs. Or are you thinking that a community setting is more your style? There are lots of programs out there that are more community based. So those are just some of the things to think about. There are also, most programs are around the same size, but our programs do vary in size, anywhere from 1 fellow to 6 fellows. So are you looking for a smaller program? Are you looking for a larger program? Some people stay at the place, or at least within the same area that they did their fellowship. So is that something you want to think about? You're going to be moving for a year potentially if you're not going to stay within the same area as your residency or wherever you are working and when you're applying for fellowship. And so do you want to move again when you leave, or do you want to have the opportunity to maybe have positions that you can apply for after fellowship within that same area? And ultimately, what I would say is that, every program provides great training. And so you can't go wrong. CL is great. I think we've the three of us have really hopefully sold our listeners on that. But these are some of the more kind of nuanced things to think about, because Artin's right. There's a lot of programs out there, and there has to be a way to narrow down.
Yeah, great. Okay, so you talked about, Dr. Shah, the location and the fact that there are chances that you will stay in the same location and the same area you do your fellowship as your first job out of the fellowship. Now, I want to take that and talk about the job market and the first job after CL fellowship. What does the job market look like for a CL psychiatrist, and how does a CL fellow go about finding a CL job once they are in their fellowship?
Yeah, great question. So first of all, I'll say a CL fellowship is a great place to be if you're looking for a CL job, because you have lots of mentors and supervisors that are going to help you kind of navigate that and open up their networks to the specific fellows. And so I think that's such a great positive for doing a CL fellowship. What I generally recommend to my fellows is to start thinking about it in the fall. A lot of our fellows take the general CL boards in September of their fellowship year. And so that's kind of the cutoff point of, okay, you don't need to think about jobs until after boards. But then after that, you start thinking about some of the things that we already talked about. How do you narrow down where you're looking for jobs? So some of the same things that we talked about for narrowing down for CL fellowship programs, you want to think about for when you're thinking about getting your first job. Location being number one. Where do you want to be? And then thinking about the type of setting that you want to be in. Do you want to work at a major academic center? Do you want to work in a community setting? If it's a community setting, do you want it affiliated with an academic center? Are you looking for primarily inpatient CL? Are you looking for outpatient CL or a mix? Are you looking for collaborative care? Most of our fellows stay within academics, but there are plenty of fellows that go out into private practice, really looking to do a CL fellowship to become more comfortable with really medically complex patients, and then taking that out into the community. And so is that something that you're looking for? So really thinking about patient population, setting, location, those are definitely some of the things to think about. And then talking to those that have gone through the process definitely most recently. So junior faculty members are a great resource to think about, oh, I just went through this. These are the things that I thought about. This is what the job market looked like. This is how I negotiated, that sort of thing. In terms of kind of what does the job market look like? Really depends on the area. If you're looking for a very rural area that has very few CL jobs, but you're really set on being in that area, you may have one job to choose from. But that location is so important to you that really is the priority. And so that makes a lot of sense. There may be somebody else that says, I'm not tied to anything, and so I can look across the whole country. And so that person may have more of an opportunity to really think about non-negotiables and, what are the things that I'm really looking for in a job, and finding something that, having at least more of a possibility of finding something that really aligns more closely with the kind of the quote perfect job. I've heard a lot of things about the perfect job. It doesn't exist. It does exist. The job that you find and you settle on, that's going to be the perfect job for you. Your first job doesn't have to be your last. I am a person that stayed at the institution that she trained at, and I'm still here 10 years after graduating. And so, I'm one example, but there are lots of people that kind of move around jobs, dependent on kind of life circumstances, as well as kind of really in search of that perfect job. So those are some of the kind of tips that I would want to get across.
Thank you, Dr. Bradley. Anything to add?
Yeah, not much to add. That was really comprehensive. So I can only speak with any real authority about the New York area because most of our fellows come, they train here, and they stay. And New York has a lot of academic medical centers, and so there are a lot of opportunities for fellows to work in CL jobs. So one of the things that I notice is that at the beginning of the year, the fellows are thinking, okay, what jobs are out there? And should I apply for them? So they're looking in the listings, that kind of thing. And this may be more true in an urban center, but I try to get them to slow down and think about, as they reach the fall and the midpoint of the year. So what's important to me in a job, rather than just applying for the jobs that they see posted, but to actively go through the process of what is important to me, what can I not live without. Do I have specific things that I'm interested in? Like Dr. Shah said, am I interested in inpatient, outpatient, or a mix of both? Are there specific patient populations I want to work in? The job listings will appear in the city, and the fellows are in demand for academic jobs. But the other thing that I encourage fellows to do is, if you have a sense of somewhere that you would like to work and you're not seeing a job listing for it, reach out to the director or the program director or the service chief for that hospital or that service, because they just may be thinking about something and it hasn't been posted yet, or something may still be coming together, and it's really good to get in that conversation. So either reach out to them, they're happy to hear from you, have a program director reach out to them, have a faculty member reach out to them, but be thinking about, where do I want to work? I tell my fellows, you worked so hard, and there may not be a perfect job, but there's a job that you're really going to be happy with, I believe, for most people. And it's worth thinking about what's important to you and where that might be. And so really, you're very well trained at this point. If you do a CL fellowship, people are going to want to work with you. So you should feel very comfortable reaching out. I think that's a little bit different from just finishing residency and often just thinking you have to take a job that you see in a listing. I think that, once you finish fellowship, and you're sort of part of that family that Dr. Shah was talking about as well, you sort of do have permission to reach out to other CL programs and say, I love your program. I know something about this, and I just want to let you know I'm, graduating. And if you have anything that's developing, please think of me.
Okay, good. I can not agree more that it's important to look at the future job that you want to take and what makes you happy, and then the location you want to be. And I can say personally, I set all my plans based on that. I applied in DC, Maryland area because I wanted to be in an academic setting, and there are 5-6 academic settings with CL jobs and research going on that I was interested in. So I can really see that aspect of consideration when you're applying for CL fellowship. So great. We talked so far about all aspects of applying to CL fellowship and the job after that. So I would like to ask my last question. Any final words or a few take-home messages for people who are listening to us and are considering CL fellowship application? Dr. Bradley.
Well, I think one theme that's I've heard pop out from both Dr. Shah and myself is getting connected to ACLP early and looking at the opportunities there is one of the best ways that somebody who's potentially interested in CL psychiatry can get to learn about the field, develop mentorship, find people who have overlapping areas of interest or expertise that can help you figure out what exactly do I want to do, and to make networking connections that are going to help you once you get to the process of interviewing for jobs or for programs.
Okay, thank you, Dr. Shah.
Yeah, I feel like Dr. Bradley stole mine. I agree. ACLP is very, very important. Two things I'll plug is there have been two webinars that have been done consistently through ACLP sponsored events, including how to apply to CL fellowship, especially during this virtual time, and finding a job in CL. And both of those are posted on the ACLP website. And so for anybody that is interested in hearing more about this from a different group of individuals, those are some great resources. So my take home point will be that, think broadly. With a background in CL, there's just so much that you can do. It allows one to really utilize their skills to move into areas of not only clinical CL, which I absolutely love, and I think most CL psychiatrists love, but also things related to hospital systems and hospital administration. So that's how I moved into kind of spending a quarter of my time working on workplace safety. And I never thought that I would want to do any sort of hospital administration work, but it has been so rewarding and really allows me to still keep that CL psychiatrist hat on, which has been really exciting.
Okay, great. I can also tell that the involvement with ACLP had a big role in my interest in CL psychiatry. I became an ACLP member as a PGY1 resident, and I applied for ACLP Trainee Travel Award as a PGY2 resident, and participation in ACLP conference, and getting to know people and the research and clinical work in the area of CL psychiatry was a big interest for me. So thank you so much, Dr. Shah and Dr. Bradley, for accepting to participate in this podcast.
Thanks so much for having us, Artin.
This was really fun, Artin.
Yeah, thank you.
Speak with you and to Sejal.